At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I am so happy to be leading this conversation during October is for livers. Of course, as a liver transplant recipient of longstanding, I think that every month is for livers and discussions about liver health. But October in particular, we reclaim our time, so to speak. And to help me do this today, I have with us a world-renowned expert and one of my favorite people in the world to help us walk through how we can create an equitable care system in liver cancer in particular. So with that, I will welcome Dr. Andrea Reid, who is amongst her many, many titles, Director of Diversity and Faculty Development in Gastroenterology at Mass General Hospital, and also Associate Dean for Student and Multicultural Affairs at Harvard University, as you all know, a place that's near and dear to my heart and my diploma wall. So Dr. Reid, welcome.
Thank you so much for having me. I'm looking forward to this conversation.
Thank you. So one of the things that I particularly love to start with, or to at least make sure that we include when we're talking to female physicians in particular, and that rarest of all too rare female physicians of color, as we hope to attract more and more, particularly to gastroenterology and hepatology. Can you maybe start off with a little bit of how you got to be a gastroenterologist, a hepatologist at Harvard, no less?
This is great. Thank you so much. Yeah, it is so important, I think, for us to tell our stories as we try and encourage others to go into the field. And I have that wonderful privilege of working with medical students and residents and fellows to be able to try and grab whoever I can to fall in love with hepatology. So I've been pretty successful, I've been told. So I went to Brown University and then to Harvard Medical School straight through without any gap year. At Harvard Medical School at the time, under that curriculum, you did sort of the individual systems-based pathophysiology, as it's called, the disease states by system. And we had a block of gastroenterology, and I was drawn to it, but had not really thought about it as a field. And then it was during my clinical clerkships that I started to say, GI is pretty cool. It has procedures. It also is quite varied in terms of the organs that are involved in care. But I still didn't have a great sense that was what I was going to do. I went into internal medicine and realized that I also really liked cardiology, at least the inpatient side of cardiology. And so I was deciding between cardiology and gastroenterology.
And we won you. How did we win you?
How did you? Well, it wasn't that hard, because ultimately I had to look back to that person in medical school who had really loved the GI block and had also loved my GI sub clerkship when I was a fourth year medical student, and thought it's the variety of GI that really drew me. And I realized that for cardiology, I was drawn to what happens on the inpatient side as a resident. But when I thought about what I wanted to be doing as an attending physician, the variety of GI, and especially the various diseases associated with the liver, that's what really grabbed me. I liked procedural things. So the combination of being able to be procedural, but at the same time, pretty cerebral at dealing with the complexities of liver disease was a slam dunk, right field for me. And so after a year between residency and fellowship, where I actually was an attending in an emergency room, so got to see really acute liver disease there in the ER as well. I came back and did my GI fellowship, and then spent a couple of years in the lab doing hepatology research, and then focused predominantly on medical education and liver disease, and have not varied too far from that since then.
We are grateful for it. Every patient who, particularly those who have found themselves in an emergency room, with people trying to figure out, and often don't have sort of liver on the brain, if you will, and aren't thinking about liver diseases, are very grateful for your expertise and experience and commitment.
Thank you.
So we're here today to talk about liver cancer in particular. I felt, and I want to understand if you agree, I felt when I came to building programs and awareness in liver cancer that there was overall discrimination and an inequity in the spending attention and resources on liver cancer versus other cancer before we got into any inequalities based on people of color or income or rural access or any of those issues. Just liver versus other cancers seem to be at a disadvantage. Do you find that to be true?
I think that is true, and I think part of the complexity around liver cancer is that the final common pathway toward liver cancer in most cases is that there's cirrhosis, right? So most liver cancer develops on a background of a very scarred, altered liver. And in the general public, as you can imagine, because of the things that lead to cirrhosis, there's already stigma around the diseases that lead to cirrhosis, as well as shame for patients. And then the other piece is that there's not great understanding of how cirrhosis should be managed. And so individual patients, on the individual patient level, patients often find themselves far removed from standard of care because they're not connected to a hepatologist or to a very knowledgeable gastroenterologist or primary care doctor who would do the kinds of work that needs to be done to make sure that we're identifying cancers early. So that's one part. So there's the stigma around the diseases. There's the lack of knowledge about how to manage patients and how to diagnose them with cirrhosis, because we don't want to diagnose people with cirrhosis when they're late in the game, when they've already got all the complications. We want to be able to diagnose people, obviously, ideally before cirrhosis, but then also to be able to identify those with cirrhosis and start screening for liver cancers early. So if you think about the variable costs, that's cost of screening. That's connection to a physician and seeing them at least twice a year. That is commitment to the screening protocols. That is being able to get access to providers that can care for you if you do have a liver cancer, which is more than just the hepatologist. That's the interventional radiologists and surgeons and others. So the whole stream of care for liver cancer that develops on the background of cirrhosis is fraught and room for lots of inequities, but also it's not funded in the same way as other cancers. It's not as well known how fast liver cancer can develop, and also how much it's increasing in the United States. So it has, we're constantly making a push to try and get more attention placed on liver cancer, recognizing that it's such a big problem. It's very difficult to treat when it's caught late, when people already have symptoms, but much easier to treat when people are screened for it and are really attached to the protocols that allow them to be identified as cirrhotic so that we can screen and then connect it to appropriate care when it develops.
That has absolutely been our experience, and why over the 10 years that we've been involved, we've been trying to move the marker earlier and earlier in the process. Can you talk about some of those drivers of liver cancer, those earlier conditions that we can start paying attention to so that people get care before they end up with cirrhosis and liver cancer?
Right. Thank you. Yes, of course. And I know we're probably speaking to an audience that knows a lot of this. So
I wouldn't assume. I came from a autoimmune liver disease and fast progressed within 2 years to transplant, and so I missed sort of all of this in my personal patient journey, and had to learn all of this when I came to this professionally. So even liver patients may not know about this progression and the sequence.
So let me start with the very basics, and recognizing, again, for those of you that already know this, just bear with me. So cirrhosis is extreme nodularity or destruction of liver tissue replaced by scar. So that's really what it is. And cirrhosis can have many different causes. And as a hepatologist, let me just say, I have I tell my patients all the time, it doesn't matter what caused it. We're going to treat you the same. We want to care for you, whether it's something that you feel embarrassed about or not. So whatever the cause, once it gets to cirrhosis, the treatment is basically the same. So the causes of cirrhosis include alcohol-related liver disease, usually from long-standing alcohol use disorder. It's very inflammatory, and alcohol can cause scarring to develop relatively quickly, although cirrhosis usually develops after 10 years or so. Not everyone that drinks heavily will get it, but those that drink heavily are at great risk for cirrhosis and subsequent liver cancer. So alcohol is one. That's the one people think about the most, but all cirrhosis is not due to alcohol. Secondly is viral hepatitis. Hepatitis C, which is much more common in people of color. Hepatitis C, though we have great treatment for it now and can eradicate it in most patients, the reality is that most people diagnosed with hepatitis C have already had it for decades before we can offer them treatment. And the damage is done. Again, that chronic inflammation and scarring is done from the beginning of hepatitis C until the liver's all scarred. So hepatitis C, long-standing hepatitis C, definitely can lead to cirrhosis, one of the leading causes for liver transplant. The third that I would mention is the one that's greatest on the rise. That's non-alcohol related fatty liver disease. Used to be called NAFLD, is now called metabolically associated steatotic liver disease, or MASLD. New terminology, basically saying fatty liver that's not caused by alcohol, but same pathway, inflammation leading to scarring, which ultimately can lead to cirrhosis in patients. And then there's the more uncommon sources, like a genetic disorder that causes overwhelming absorption of iron from the intestines, or an abnormal genetic markers that lead you to absorb too much iron. Iron in the liver is stored there, not a good thing. Inflammatory causes can cause cirrhosis. And then there are the less common causes, like what you have had, including PSC, primary sclerosing cholangitis, often in people with inflammatory bowel disease, but not always. PBC, primary biliary cholangitis, more common in middle-aged and older women, can progress to cirrhosis as well. And then there's other even rarer conditions like Wilson disease that can lead to abnormality of copper metabolism that can lead to it. Alpha-1 antitrypsin deficiency, all the pathway being to cirrhosis. Now, the other thing that can lead to liver cancer, not necessarily always associated with cirrhosis, is hepatitis B, which is a leading cause of liver cancer, especially in individuals from endemic areas where hepatitis B is extremely common, passed from mother to child. Hepatitis B really is the only condition that we can speak of in large numbers where liver cancer can develop even without cirrhosis. So our screening protocols for hepatitis B are different than all the other conditions that I mentioned. And there's some other sort of more uncommon causes of cirrhosis, but those are the big ones. And the big three really would be viral hepatitis, non-alcoholic liver disease, or MASLD, metabolically associated steatotic liver disease, and alcohol. Those are kind of the top three, but then there are these other things we don't ever want to forget, that they can also be quite silent and just result in abnormal liver tests, and again, often ignored in the general setting because they're not causing any symptoms, but they can lead to cirrhosis quite silently.
And I think that, gets to both a message of hope that if we are, diligent in our hepatitis B vaccination, our hepatitis C curing, our, earlier approaches to fatty liver disease with diet and exercise, and now new FDA approved treatments, that we can prevent a lot of cancer. And that's not something that we can always say about a lot of other cancers, that we know how to prevent maybe 70% of cancers if we pay attention earlier. And that's a message for primary care doctors and everyone who may touch a patient, not just for hepatologists as well.
Absolutely.
So if we have these larger problems with anyone with an underlying liver disease and hoping to be screened regularly for liver cancer, what are some of the specific inequalities that may affect different communities within the whole?
Well, I think, they are myriad, really. If you think about the fact that let's talk about on the provider level first.
Mhm.
Although that probably is not where the most amount of inequities start, but I just want to speak to that personally.
Mhm.
The reality is that the variety of patients that have liver disease, some things they associate with shame and stigma, and others they do not.
Mhm.
And the most important thing is having a relationship with a provider that is caring and understanding and not judgmental. And
Mhm.
that is a huge barrier to actually getting linked to evidence-based care is if the patient has liver disease but feels like they did it to themselves and they
Right.
then don't follow up with care,
Mhm.
or they connect with a provider but that provider is not really proactive about saying, you have liver disease, we want to stage it, and depending upon the stage we will connect you to appropriate care. So
Mhm.
that providers being both open and caring but also being knowledgeable about how to get individuals staged or how to connect them to a liver specialist that can stage disease. And what I mean by staging is determine the amount of scar that's in the liver. And one of the biggest concerns that we have as hepatologists is that often patients and some providers feel like the elevation of the liver enzymes, the liver associated enzymes,
Mhm.
will determine whether or not they have scarring or not. And we know that
Liver
those things are
enzymes lie.
absolutely disconnected. So
Mhm.
often patients that get diagnosed with cirrhosis, especially those with fatty liver disease,
Mhm.
often those individuals have normal liver enzymes because basically the liver enzymes are no longer inflamed, they're scarred. And so
Right.
they don't have elevated liver tests, which is very disconcerting to patients. How
Mhm.
can it be that my liver test finally improved and now you're diagnosing me with
Right.
cirrhosis? But that's actually very common.
Mhm.
And so it's really important for providers to both be knowledgeable, but now let me get to a little bit about the diversity of providers.
Mhm.
So as you stated at the outset, the number of providers that are individuals of color is actually quite low. And so if patients often are looking for some degree of cultural concordance when
Mhm.
they're seeking providers to try and get appropriate evidence-based care. And the numbers just don't add up. We have an
Mhm.
overrepresentation of chronic liver disease amongst individuals of color, especially amongst those that are American Indian, Alaskan Natives, African American, and those that are Latino or Latinx, have a higher rate of liver disease than those who are white, non-Hispanic. And yet the number of providers that meet those demographics is extremely low. So that is, for some patients, a real barrier to wanting to lean into liver care. And unfortunately, those numbers, although we are working very hard to improve them in so
Yeah.
many different ways,
Mhm.
that unfortunately is one of the hardest barriers to break because it takes not only getting people interested in medicine, getting them through medical
Mhm.
school, then into residency, and then interested in GI,
Right.
and then subsequently interested in hepatology. So that's a long, long, long way to go. But we're working hard at it. We're working really
Right.
hard at it. Absent increasing the demographics of those that
Mhm.
care for patients quickly, which we can't do
Mhm.
quickly, but we're working hard.
Yeah.
What we really need is individuals that are culturally humble, whatever their background, that they are leaning into the patients. And as I stated at the outset, saying there is no stigma
Mhm.
related to what caused your liver disease,
Mhm.
and that we are going to get you connected to someone who will listen to you, who will talk to you about your liver
Mhm.
disease, ways to make it better, and if you have cirrhosis, what appropriate screening is. And that can be a real barrier. On the patient side, the barrier is often just understanding that liver disease is progressive, but that
Mhm.
there are treatments available, and that we can, in some ways, reverse liver disease. We can't reverse cirrhosis, but we
Right.
can reverse liver disease if it's
Mhm.
caught early. So, them coming and advocating to them, I've had these abnormal liver tests for a little while, and I think I'd like to see a liver specialist to
Mhm.
understand what I can do to make things better. So, that
Right.
self advocacy is really important, understanding your own body, and then committing to those things that help to improve it. So if it's alcohol related,
Mhm.
stopping the alcohol intake with whatever supports you need to stop alcohol. Again, for hepatitis C, we have good treatments available. It's not experimental therapy.
Mhm.
These are good treatments that reverse it, and really being aware that we can make it better. For
Mhm.
hepatitis B, similarly, being treated for the hepatitis B, for non-alcohol related liver disease, there are things we can do before you get to cirrhosis to try and make things better. So advocating for not only connecting to appropriate liver care, but also being ready to do the hard work that is often required to stop or to slow progression of disease.
If I may, I want to build on a point that you made about the power and the impact of trust between a patient and physician. And it's a story that I haven't told very often, but many people know that my husband is a physician and was one of the longest serving board members of the Association of Black Cardiologists, even though he's neither Black nor cardiologist. And when we were first married, he would see me go out the door to doctor's appointments, and I would be all dressed up. And finally, he asked me, "Where are you going? Who are you seeing?" And I had to explain to him that I dressed up for doctor's appointment, not because I was flirting with anybody. I was just trying to get good care. I was trying to make sure that they signal to them that I had health insurance and that I was worth treating, that I was worth their time and attention, that I would be more likely to, adhere to instructions if they gave them to me, that I could have, coherent conversations with them, and basically that I was a valuable person. And it hurt his heart. He said, as a physician, it hurt his heart. Certainly, as my husband who loved me, it hurt his heart. And it had never occurred to him as a white physician that was the position that, as I say, even someone like me who is well educated, I'm by definition and training an advocate. I graduated from law school, and yet I still felt that I needed to put on the whole armor of God to go to a doctor's appointment, just so I could come out on the other side of it being treated well. And so when you add on having conditions that, as you said, are associated with a lot of shame and stigma, that it's an added burden and anxiety level to sort of prove yourself, that a lot of patients feel. And so a lot of that is not present when you have a physician from the same culture, who maybe grew up with parents using the same language, who ate some of the same foods, and maybe, in the case of fatty liver disease, can talk you out of eating the same foods, or, can teach you how to adjust. But if you can get through the shame and the stigma and feel that there's empathy and connection, there's so much more to build on in a very short, often 10 or 15 minute, visit, that I think there's more room for health and trust to grow in those situations, particularly for patients who maybe don't have this background and who didn't grow up in an environment where they're trying to stand toe to toe with white physicians every day. It's even more important to make sure that someone on the care team looks like them, understands what it means when they're patting their hair, can detect a dermatology thing, a skin rash with skin color, can tell you that if you're on prednisone or an immunosuppressant, you still need sunscreen even though you're Black. Just somebody who can connect with you and who understands and can open up those types of conversations, that they may be live or die conversations. They may be the thing that you share as a patient with your doctor that leads to the diagnosis or leads to the change or the referral or the extra test that can save someone's life. And so, that's why our partnership with the Association of Black Gastroenterologists and Hepatologists is so important. But that, as you said, every doctor needs to be delivering culturally competent care and be aware of these issues and these dynamics.
I think I can't say it any better. I would just add that one of my responsibilities here at MGH is to push us as a practice, because though we have 4 Black women on faculty here, that 2 of us are hepatologists, focused in slightly different areas, and we have a general gastroenterologist really focused on colon cancer disparity, and then we have an advanced endoscopist who does global health. We do very different things, but all of us represent, I think, important contributions to the field. We all bring
Mhm.
something special, but we also need to educate and do educate everyone on how to develop equitable health, equitable care. And that means that anyone that sees a patient of diverse background,
Mhm.
no matter what that diversity is, we want them to have the tools to be able to say, how can I treat you best? How can I meet you where you are?
Mhm.
How do I show respect? And how do I consider in any patient encounter, in any decisions we make as a
Mhm.
practice, who could be left behind by the decisions that we make? So
Mhm.
I ask that question anytime we're talking about new strategies, new ways of doing things globally within our department.
Mhm.
Who benefits and who could be left behind? So those that English is not their first language,
Right.
those with limited health literacy,
Mhm.
rural individuals that live in rural Massachusetts or rural New England. How
Right.
do we benefit them? How do we benefit how do women feel knowing
Mhm.
that women are underrepresented in gastroenterology and may get disparate care? So
Right.
there's lots of things beyond race and ethnicity that we have to
Mhm.
think about in terms of equitable care. And we have to be culturally humble enough to say, I can't become culturally competent because that assumes that you just learn about a culture and you're done. But
Mhm.
how can I be culturally humble saying, let me meet you where you are and let me ask questions and make no assumptions about
Mhm.
how best to reach you. And we all have to do that, but we have to be challenged to do that.
Absolutely. Absolutely. I think, across our team at the Global Liver Institute, we have people, and I love learning from how can I be more culturally competent as we're dealing with Native communities. And so our staff from those communities, teach us every day, how can I reach out? And I've had the advantage of being in liver disease for a long time, having worked with a lot of Asian and Asian American communities, but still our staff from those communities, tell us, I know we're successful when like some of these like Vietnamese mom says, this is, they learned about it in the Vietnamese, newspaper. And I'm like, okay, in Colorado or something. I'm like, that's when I know we've succeeded. When I get that feedback from these different communities that we have, met them where they are, often in their language or with
Mhm.
examples that make sense to them and dealing with issues like transportation or translation that matter to them and could be a barrier to care.
Absolutely.
So as we close out this, I feel like we've been doing lightning rounds the whole time. You've packed a lot of information in this. I also, I want to ask you one question before we sort of, have give you the last word. Many medical schools, I am happy to see, are have attracted large philanthropic gifts, so that medical school is free
Mhm.
in some places. Do you think that will make an impact on bringing more students from low income environments, from different cultural environments, to consider medicine and to being maybe in places where there are high need?
I wish. We can always be hopeful, but if
Mhm.
we look at the examples for some of the schools off so far that have gotten these very large philanthropic gifts, in fact, it makes them more selective, not less so.
Mhm.
First of all, so higher MCAT scores,
Mhm.
higher GPAs. They're not saving spaces necessarily for
Mhm.
those individuals that might have more hurdles to overcome, more distance to travel to get to
Right.
medicine. So I don't think we're seeing, and I'd like to be optimistic and think that
Mhm.
it'll increase diversity in medicine, but I don't think that it has been borne out just yet.
Right. Well, I think
Unless
that's
we
important to
Yeah,
know because
yeah.
people are like, okay, I read that in the newspaper, all done, problem solved, and it's not that easy.
Well, think about it. It
Hmm.
basically means that they're going to get increased numbers of applications and people
Right.
that might not have thought of those schools before for
Hmm.
whatever reason now to consider a tuition-free education will apply. So their selectivity will
Hmm.
likely go up. But I don't want that to discourage individuals that are interested in medicine no matter what your metrics look like. You are more than your numbers. We are
Hmm.
all more than our numbers and what I try to do is spend time talking to students young younger and younger in the process, explaining why medicine is a great field. Because the reality is some of our best and brightest are not choosing medicine, they're choosing business or law or other fields or teaching. We'd like them to consider medicine because they're highly capable. It's just they have to see this as a viable career and one that brings just the greatest amount of satisfaction. It's a wonderful, wonderful career, but it is a very long path.
As the daughter of a 6th grade science teacher who was also the only girl on the chem team, but chose law because I didn't see people like me, who looked like me in medicine. I really didn't know that was a choice, but I could tell you, 5 famous Black lawyers off the top of my head. And so I think that it's very important that mentorship and that pull all the way through happens.
I talk to high school students. I've been to kindergarten classrooms. I'll talk to anybody to try and get them to see that medicine is not what you see on television. It is exciting, it is fulfilling, and it is not without its challenges, which discourages a lot of people once they get to college. The barrier of entry is still super high, and having free medical school won't change the barrier of entry for many students, but it's still a worthwhile path to follow. And hepatology is just the best.
Absolutely. I'm also happy to help anybody with their math homework if they need it.
Absolutely.
And I do know the credit cycle. So, support may be where you don't expect it, but we're here. We're here. And I thank you so much for everything.
Oh, you're so welcome. You're so welcome.
And there we go.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.